And so we're going to get started here now. So hello, everyone. My name is Jackie Kernick. I'm a staff member at the College of Public Health, and this event is sponsored by Staff Council. Thank you for joining us today for the University of Iowa College of Public Health Spotlight. The Spotlight series allows CPH faculty, staff, and students to connect with one another and learn about topics across the disciplines of public health. These events occur throughout the semester, and today we're pleased to continue the CPH Spotlight series in the virtual space, with today's topic being about COVID-19. And we have several panelists, including Dr. Christine Petersen, who is a professor of infectious disease epidemiology and the director of Center of Emerging Infectious Diseases, Bonnie Rubin, who is a member of the Johnson County Board of Health and works in the Midwestern Public Health Training Center, and Dr. Michael Pentella, who is the director of the State Hygienic Lab and a clinical professor in epidemiology. So to explain the format of the event, we will have our three speakers give presentations, and then I will facilitate a discussion with questions that were pre-submitted using the Qualtrics survey. So thanks to those who submitted questions. But that means that we will not be taking questions from the participants on the call today, just to manage everything and make it easier to facilitate. As we begin, I would note that the content of today's presentation is for educational purposes only. The presenters are not providing medical advice, and their views are their own and not those of the University of Iowa. So first, we have Dr. Christine Petersen, and as of today, she is a professor of infectious disease epidemiology and the director of Center for Emerging Infectious Diseases within the University of Iowa College of Public Health. As the director of the Center for Emerging Infectious Diseases, Dr. Petersen coordinates One Health activities focused on understanding, detecting, and preventing emerging zoonotic disease globally. Through this work, she established collaborative programs between the University of Iowa College of Public Health and the Carver College of Medicine, the Iowa State Hygienic Laboratory, and the Veterinarian Diagnostic Laboratory at the Iowa State University. Dr. Petersen's scholarly work has focused on recognition and prevention of diseases transmitted between animals and people, zoonotic diseases like SARS and CoV. It's a little O, so I don't know. Dr. Petersen is deputy editor of the PLOS Neglected Tropical Diseases and editor for the Infection and Immunity of PLOS Pathogens. I know I'm not saying that right, but hopefully Dr. Petersen will let me know. And so Dr. Petersen also has a collaborative group that holds the Fogarty Institute and the NIAID funding to provide better prevention to control measures for both tropical and domestic infectious diseases using field studies and statistical modeling. And she works on these in Brazil, India, and the US. Dr. Petersen teaches joint coursework in medical, veterinary, and global health, and also work related to diagnosis, treatment, and prevention of disease. With all of that, please welcome Dr. Christine Petersen.
Great, it's so wonderful to be with you all today. I think we can move to the next slide, Jackie.
Sure.
And thank you all so much for joining us on this April Fool's Day. This is just my little slide of how the whole thing might have started. It's of course a joke, it's April Fool's. As far as we know, I'm going to be talking to you about what we really think happened. But this is a fun, for those of you who have cats, I do imagine cats knocking off the counter, various things. Thank you so much to the Staff Council for inviting me to speak today. And what I'm going to be covering is the basics of these coronaviruses, where they are in the world at all times, and then what might have led to the emergence of this disease this time. And then I'll hand it off to the public health professionals to tell you more about what's happening locally. So coronaviruses are found to infect many different mammals. They are known as RNA viruses, and that's important just because it takes an extra step then to detect the genetic material of these viruses. And one more step means one more thing that has to be done in order to detect them. They can mutate and recombine, but their mutation rate has been found to be not like that of influenza or HIV, which has very sloppy replication, because it does have some editing ability. And based on the genetic code of the current coronavirus, it's thought that it also has this editing ability, much like the previous SARS virus. Important to note, these do have a source in bats. Anytime you want to talk about pretty much any emerging infectious virus, you can probably say they came from bats and be right. But that's definitely true for this novel strain. Next slide, please, Jackie. Ooh, there you go. So this is just a little schema that, like I just said, talks about what are the normal reservoirs of these viruses. And at the bottom, I don't know, you can see that, yeah, there we go. So if you want to point to the bottom ones, we have both MERS and SARS. And as you see toward the middle of the circle in the green part, there are bats, specifically horseshoe bats. And then there's different animals that are thought to be the intermediate host, and then it spills over into people. So these viruses are found in animals at all times, and then it's just a question of what are the events that lead it to spill over into people. So if you want to do the next click, Jackie. With the current virus, there's been lots of hypotheses. The first one, which was really strange, was that it was somehow in snakes. Interestingly, pangolins, yes, Patrick, you did pronounce it right, are snake-eating animals. But so far, despite the fact that the virus that's found in pangolins is very similar to the one that's been found in people, the one in bats is even closer, which makes us think that even though pangolins, the poor guys, get a similar virus to what we find in people at present, they're probably not the reservoir. And we don't really know, and we may never know just because of the cleaning that happened after this outbreak started. But we'll see what we can find. Next slide, please. So as I was just mentioning, both the 2003 SARS virus and then the current one are both thought to have started in live markets. And this is a picture that did come out of the 2003 outbreak, but it's a decent depiction of how these animals are brought to the markets and are stacked one on top of each other live, and then they're butchered, they're in the market, and then brought home and eaten. And as you can imagine, that's not exactly a very hygienic environment for food, and it does lead to transmission events like what happened in December. Next slide, please. So with SARS in 2003, after a certain number of people were thought to have gotten the virus by eating animals that were infected, it then started spreading throughout the human population. And this is a classic depiction of the Metropole Hotel, which is thought to have had the largest transmission event of that previous SARS epidemic, which led to spread to multiple continents, making it a pandemic. So the index case, seen in red, and his room in the hotel, also seen in red, is where a professor who had been at a large dinner with a conference unfortunately got very ill and vomited on the floor. That's the little gray ring around where his little person is standing. And then as people went back and forth from the elevators that are off on the left-hand side, they created an aerosol and people were able to get infected with the virus that was basically in the hallway floor. Next slide, please. So these super spreading events we also think are happening in the current virus spread of COVID-19. So there's been multiple locations and events that people have talked about. There was a big Biogen conference in Boston that is thought to be one of the events that spread it through the United States. Of course, in France, there is this original epicenter in one of the Swiss chalets, or French chalets, I think, for skiing. And then more recently, we know that in long-term care facilities, they are real sources of infection across all of the people, unfortunately, in that facility. And events like funerals, there was one in Albany, Georgia that was cited in the New York Times as a real super spreading event. So that's why keeping people down to like 10 is a real public health directive, because the more people you have together, the more that can get the virus through these transmission events of droplets or aerosol, and then that can be transmitted across the population. Next slide, Jackie. So why do we think this started in bats and then started to spread? Well, this was a paper that came out actually almost a month ago now, but it shows the genetic sequences of the novel virus up on the top part, and then it compares a bat virus to the current human virus. So the bat virus is the one that's down below, and the human virus is the one that's up above, and it's only a difference of 1 or 2 nucleotides. So that's 1 or 2 A's or T's or G's that are different. And in many of these places, there's a lot of sequence homology. That's what the different percents are showing in this slide. And the only place that's different is down on the left-hand side. You can see some more differences. But this did come from a horseshoe bat, and we do think that that's the reservoir of this virus. Next slide. So this is a picture of the actual market that was rapidly disinfected and closed after it was linked to the outbreak. And that's why we are unlikely to ever find the actual animal or animals that this started from, because it was depopulated and the place has been completely scrubbed of anything that is living. Next slide. So this just reminds you all that animal health and human health is linked. Certainly with the environment as well. And we need to pay attention to what's circulating in multiple species to be able to keep these from spreading. China has invoked specific edicts about what animals should and should not be food. And I think it said something like 10 species are now what they're supposed to be eating of mammals. But even with the last SARS outbreak, there was a limit of what could be bought at the markets, and a lot of directives toward the hygiene that should have been kept in these places. But unfortunately, when the risk goes away and people have some time pass, often it is not as easy to keep doing all those cleaning measures and not eat the things that you really like. So it's going to be very interesting to see what sort of measures follow after this. And I think that's, so this is just a little slide to say what my center has been doing. So the Center for Emerging Infectious Diseases is built around a group of people that do work in both animal and human health. And it was my pleasure to help people from the State Hygienic Lab and travel with Mike Pentella over to the veterinary college, where I had been faculty before I joined the University of Iowa, to talk about commonalities that they have between the veterinary diagnostic lab and the state hygienic lab, and ways that they could potentially collaborate in the future, because laying that groundwork is so critical that in situations like that, you then know the people and can reach out. And I saw recently a press release that they were able to get some reagents from the veterinary diagnostic lab, which made me thrilled. My group is working with a good friend and colleague in Nigeria that reported the first COVID-19 case there. And we're hoping to help them further with statistical analyses and modeling as needed. We took every extra box of gloves and gowns over to the emergency department to help them, because we've ramped down a lot of the work that we're doing in our lab. And then we're happy to be doing educational and awareness events like this. And my next slide is just a question slide, and thank you, of course, to all of the health professionals, the public health professionals who, as I was talking with Patrick Ripa before this, are really defining what the front line is of this epidemic. And then all the scientific and clinical staff that is providing us with the ability to find, detect, treat, and prevent this disease. Thank you.
Thank you very much, Christine. That was very interesting, and I'm looking forward to talking more about that. Any questions during the Q&A time? Our next person that we have is Bonnie Rubin. And so I'm trying to share that one. Let me see how this. Christine, are you still seeing your own slides?
Yeah, I am. So you might have to close mine down to get to the next one.
I think I. Okay, so our next presenter is Bonnie Rubin, and I will tell you a little bit about her. So Bonnie has a CLS, MBA, and MHA, and is practicing retirement after almost 40 years in laboratory medicine. She now devotes her time to her passions and is currently a member of the Johnson County Board of Health, a site surveyor for the Public Health Accreditation Board, an adjunct assistant professor in the University of Iowa College of Public Health, and a board member of the Clinical Laboratory Management Association, and appointed member to the Clinical Laboratory Improvement Advisory Committee. She also maintains her public health and laboratory professional involvement through the Iowa Public Health Association and the Association of Public Health Laboratories. And Bonnie, are you on? I'll get your slides to be full screen. Bonnie, are you muted, or can you hear us or talk? Bonnie? She was having some trouble with her sound earlier. Okay, so Bonnie, you might want to call in using your phone like you did earlier, because I don't see a microphone for yours on the managed participants. So while Bonnie's doing that, if Christine and Mike are on the line, I wanted to ask some questions that I was going to direct to you anyways. Would that be okay?
Sure.
Great. So, so some of the questions that we had for either Mike or Christine would be, have there been any positive results from the work of transfusing COVID-19 patients with plasma from COVID-19 infection survivors?
Well, I know that's being looked at in the United States, but I don't think it's been used yet in the United States from anything that I've seen. Christy, have you seen anything?
Yeah, so I saw a brief report indicating that they had done that in Wuhan, China, but it was a limited number of cases. So they did see positive results, but because of course it wasn't in any way blinded or randomized, they didn't feel like they could make many conclusions, but they can say the people survived.
Well, good.
And this is Bonnie. Can you hear me now?
Yes.
Fine. Great. Thank you.
Great. Well,
and
thanks
thank you. Go ahead.
Oh, I was just going to say thanks for answering those questions, and we can get started with Bonnie's presentation.
And thank you very much for filling in, Chris and Mike. For those of you who are unfamiliar, the letter CLS stands for Clinical Laboratory Scientist, which is a 4-year bachelor's degree in clinical laboratory science, where you're trained to work in all the different aspects of a clinical lab, be it blood bank, chemistry, immunology. So I just wanted to let you guys help you understand my background. Next slide, please. My talk is going to be more in the perspective of someone kind of on the outside looking and watching from the outside of what's going on, but still being somewhat involved in public health and in laboratory medicine. And what I'm finding is, and most of you are probably aware of it, is that a lot of folks are getting their information from some interesting sources. So I wanted to share with you what I'm what I do, what I'm looking at throughout the day, throughout the week, to get some actual accurate information. And I've signed up for the Iowa Governor's Press Conferences. I watch those every day at 2:30. The Johnson County Emergency Operations Center here in our county has a presentation twice a week, and I am sure that different emergency operations centers throughout the states and the counties also have these. I get to participate in a lot of different specific to our discipline conference calls as part of an appointed member for the Clinical Laboratory Improvement Advisory Committee. I participate in the CDC Division of Laboratory Systems COVID call, and that's happening weekly and is sponsored and is attended by all the different laboratories throughout the United States, including public, private hospital labs. And then the State Hygienic Laboratory is having a weekly call, and I'll be participating in that. The State Hygienic Laboratory has a system that they can connect to all of the clinical laboratories throughout Iowa as part of their emergency preparedness planning. And it's been in existence for several years, since about 2002. Next slide, please. Then my other sources of information is I have subscribed so that on email I get notices when the governor's office and when the Johnson County Public Health Department sends out press releases. And I'm sure wherever you are, you can subscribe to either your governor's or your local public health press release notices. And finally, the different websites, and these are really common, I think, to all of us in public health. Of course, the CDC, the FDA, and the Centers for Medicare and Medicaid Services are really good sites. They're constantly being updated, and those are what we go to get the most current guidelines. I believe Dr. Pentella has some of the links on his presentation for those websites. And I also go to, and the public can go to these too, is the Association of Public Health Labs, the American Public Health Association website, and then the other two websites I have listed there, Nature and Astos, because they're all updating constantly of what guidelines are and what's available and what things you need to know. And finally, the Midwestern Public Health Training Center. Towards the end of this presentation, I'll have some slides to give you some of what's available specifically related to COVID. But that has some really interesting stuff on it too, so you can learn more about COVID and other things. Next slide, please. Where I don't routinely search for information, and most of you are probably would agree with some of this, is Facebook. As we're staying connected to a lot of friends, we're seeing some humor there. One of the things I like to look at is Pluto Living, which you might be familiar with, the little dog that tells us how to protect ourselves. But there are a lot of times now Facebook and YouTube are being used to post the videos of press conferences and things like that. So I go there for those only. I go to YouTube for more humor. I barely, Twitter, I try to ignore. Television, I hear it, but again, it's so much hype and we never get the full story a lot of times. And yes, I still get a hard copy newspaper because it's really interesting, at least for me, to see what's going on here. Next slide, please. There are some things in emergency management I'm discovering, and I've realized I've known it somewhat, but now with this whole public health emergency and talking to friends and family and other healthcare professionals, there's so much that people don't realize, and they just assume this is how it works. Most people are not aware that CDC is not a regulatory agency. CDC is there to provide scientifically based evidence, to recommend and guide us to what we want to do. So when CDC gives us a list of what we should do for how we should test, how we should evaluate patients, it's at the state level that your medical director and usually your Department of Public Health is the one who says, I will do those, or we will make them more strict, or we will modify them to fit our situation in our state. The FDA and CMS are regulatory agencies. So what they say, we have to do. So a lot of times I think people need to be aware of those differences. The other thing is that CDC has a huge campus. Those of you who have been in Atlanta by Emory, you have seen the CDC campus is huge. but they are not designed to handle significant volumes of diagnostic testing. That is why we have the laboratory response network established throughout the nation so that our state laboratories are to be the ones that can handle the more significant volumes of diagnostic testing or surveillance testing needed at the state level. And that's the existence of the laboratory response network too, to be able to give ourselves at the state level support with other states. So if we need help. Now with this particular public health emergency, this laboratory response network and the whole system has been strained before by multiple reasons. And then I think people need to be aware there are federal laws that kind of guide how a national emergency is governed and the flow of it and how things happen. So it's pretty interesting if you want to take the time. They're not easy reads, but they're not hard reads. The National Emergencies Act, the Public Health Service Act, very important, the Stafford Act, and then there's a National Security and Homeland Security President Directive. Those really govern how we respond to national emergencies. Next slide, please. And the other things that people I'm finding are not aware of is that the governor is responsible for declaring a state of emergency for their state. And in order to do that, they do that primarily to get federal support, but to expand a whole lot more access to a lot of different support systems. In this particular event, when the president declared a national public health emergency, it was done prior to some of the states declaring their own state of emergency, but this allowed a release of a lot of federal funds from the reserve so everybody can start working on response. And finally, folks are unaware that since 9/11 and the anthrax litter event, public health and healthcare and all of our partners in emergency response have continuously been actively working and planning and preparing. Everyone has developed their emergency response plans. We have our continuity of operations plans. We've continuously trained and exercised and drilled for these kind of disasters. It's required by the grant funding we get from the Public Health Emergency Cooperative Agreement Program. However, that funding has continuously been decreased for the past 10 to 12 years. We call it the curve of complacency, whereas things are going and we can handle certain things like what Dr. Petersen mentioned with the SARS and the MERS, there's a sense of complacency that, oh, we can handle it and everything's in place and things will keep going and things get defunded. And so we've been working with the resources that we have, the funding we have, but it's going to be interesting to see how public health and emergency response funding is impacted by this. Next slide, please. So with my hat of being on the Clinical Laboratory Improvement Amendment Advisory Committee, and I participate in these calls with CDC, FDA, and CMS all are on this call to give us updates. So I thought you'd share some of the things from our last call this past week. CDC is developing a set of assays to detect antibodies. However, CDC is not intending to pursue an emergency use authorization for their assay, since they do not intend to use that test for diagnostic purpose. However, FDA is reviewing some assays for diagnostic serology antibody testing. At the time of the call, they had said that they hope to have some approved within the week. And if I'm correct, they did approve the Cepheid Gene Expert and the testing that it can do this past week. CMS has issued a new guidance. Now, CMS is a regulatory agent for the personnel standards and personnel actions and quality performance standards for all laboratories performing clinical tests. They issued a new guidance, but their guidance is only applicable during this particular public health emergency. And that guidance is giving us the opportunity to do what they call an expedited CLIA certification. Every laboratory that's performing a clinical test for the human diagnosis or treatment or therapy has to be certified by law by CLIA. It usually is a process that takes some time. In this case, though, they have created an expedited process, similar to the FDA expediting their review of new tests. The law requires certain standards and certifications if laboratory data and slides are going to be reviewed remotely. In this case, since we have so many stay-at-home shelter-in-place mandates, they have made exceptions to that rule too, and what certifications and paperwork is there. And finally, some of you might be interested in seeing that CDC is developing a guidance on decontamination on the reuse of PPE, personal protective equipment, and that should be coming out next week. Next slide, please. At the county level, with my hat on as a member of the Board of Health, it's been an interesting time. Right now here in Iowa, the big discussion is sheltering in place versus just safer at home, and what kind of level of recommendations versus mandates do we want the governor to have. Many states around us have done the mandated stay at home, shelter in place activity. Right now in Iowa, it's primarily recommendations that people should stay at home and only go out when necessary. An interesting thing in the conversation for public health is that sheltering in place was a concept, and the rules of engagement for sheltering in place were primarily thought about and created thinking about natural disasters and maybe outbreaks that were not as worldwide in pandemic. So we've had to rethink what does this really mean and what's required. We've discovered here we have a need for targeted messaging, even though there's so much on social media and TV and papers. We realize that there are certain communities, neighborhoods, populations that just aren't getting it. They're having parties at their houses with 25 people or more. People who are at home are saying, come on over for a haircut, come on over for a mani-pedi. We're seeing a fair number of families who, because they're home, they're out playing, and you have multiple children in a big group. And so we've had the conversation that we're not doing a great job of messaging to people that it's not because you might be sick and give it to someone. You don't know where that person you're interacting with has been, and they might be sick or infectious, and you might get it. So it's an interesting thing of how do we message to make sure everybody gets it. And then, of course, there's that whole who has the authority to do what at the state, county, and city levels. And it's been a very, very busy time for the city and county attorneys to figure out who can declare what and what can we mandate versus what can we only recommend. And then the big topic of how much does law enforcement get involved with this, and what can they do, or what should they be expected to do? How much enforcement is going to be necessary, or can we even do legally? And then we have a huge conversation about what is an essential service. So I added that essential service, the definition is the one recommended by the U.S. Department of Homeland Security. So next slide, please. And this you'll find from that website is from the Cyber Infrastructure Division of Homeland Security, where at least for COVID, these are the areas that they're saying are essential critical infrastructure workers. And this will get updated every week about what area is considered to be an essential service. Next slide, please. So then let's go to the Midwestern Public Health Training Center, of which I'm a part of with the College of over at the University of Iowa. We're one of 10 regional public health training centers, and we cover a 4-state region of Iowa, Kansas, Missouri, and Nebraska. The goal or mission of our group is to improve public health by training, management, training, education, and really working on the competencies of the public health workforce. Next slide. And on our website, we have some resources that folks can go to for some additional information. These CDC interactive maps and the World Health Organization rolling updates are very interesting and very helpful to watch as you're trying to understand where are the peaks, what's happening, and how the infection's rolling. It's always interesting to watch those kind of maps when something's first starting and you start seeing it across the United States and the world. Next slide. We also have a lot of communication resources. So if you're involved in working on communications and messaging, these resources here on our site will be very helpful. Next slide. And then finally, one of the things that we're really having a conversation about in public health is the mental health of people. Physical health is very important, but mental health, especially for the people who are sheltering in place. And one of my fellow Board of Health members pointed out in a call the other day, being home with her children 24/7 now can be somewhat stressful. So here are a lot of different resources for you to use, or feel free to pass along. Next slide. And then finally, there are things as a laboratorian and a public health professional I just really wish people were aware of. The world of laboratory medicine is the most regulated health field in healthcare. You can't just go buy a laboratory instrument and start doing a test. As I said earlier, the FDA, which is a regulatory agency, they have to approve that instrument before it can go on market to make sure it really does what the manufacturer says it does, and it has to be approved for all the tests that they say that system can do. CLIA federal laws, as I said before, control the personnel and the quality of any site that performs a laboratory test. And they have to demonstrate that once they get that new instrument in, it actually does work the way the manufacturer has said it works. In addition to keeping up with COVID testing, I think it's important that people are aware that state public health laboratories are continuing to do all the other stuff that they're required and expected to do. For example, the state hygienic laboratory, they're doing a ton of COVID testing, but they're also staying up with all their other infection control, their environmental testing. More importantly, they continue to test every baby that's been born in Iowa, North Dakota, South Dakota, and Alaska for all their metabolic disorder screening. So they're still a very, very busy organization. Next slide. And then there's always the semantics. Drive-up or drive-through testing is really drive-up sample collection. But, you know, I think the average person thinks they're going to drive up and get a test result, which isn't what's going to happen. Johnson County Department has a video on how they conduct disease investigations for COVID. It might be very helpful for folks because the disease investigation process continuously changes as we have more testing, as we see more cases. And Dr. Petersen, she addressed this too, of when will what I consider to be a root cause of these worldwide outbreaks be addressed, which is the open markets in the Asian countries. Next slide. And finally, there's me. I was in Sedona before this all happened, and it was really nice hiking. Now I'm back in Iowa City, sheltering in place. And I thank you very much for everyone else who are considered essential workers and are doing all this work for us here in the United States and throughout the world. Thank you very much.
Thank you, Bonnie. That was great. I'm excited to hear more and also introduce our final speaker. Can everybody see what I'm sharing? Yes, Dr. Pentella.
Yes.
So a little bit about Dr. Pentella. So Dr. Michael Pentella is the clinical professor at the University of Iowa in the Department of Epidemiology. In the Department of Epidemiology. And he is the director of the Iowa State Hygienic Laboratory. His experience spans over 40 years in clinical microbiology and public health laboratories. He is certified as an American Board of Medical Microbiology diplomat, a specialist in microbiology through the American Society for Clinical Pathology, and certified in infection control through the Association of Professionals in Infection Control. Dr. Pentella is a member of the Association of Public Health Laboratories, Infectious Disease Committee, the APHL Biosafety and Biosecurity Committee, and the American Society for Microbiology Lab Practices Committee. Over the years, he has made several contributions that have improved the practice of clinical microbiology and biosafety. He has written over 45 articles and 15 book chapters. And without further ado, Dr. Pentella.
Thank you very much, Jackie, and thank you to Staff Council for the invitation to speak today. Are you guys able to hear me pretty good?
Yes.
Very good, thanks. So move on to the next slide. I'll try to make this brief today so we can get to the questions. And I just wanted to show you that COVID-19, really serious, very important, but we have faced a lot of very serious emerging pathogens throughout the decades. I go back on this slide some 40 to 50 years, and some of these pathogens you will recognize in that we take for routine now that they occur from time to time. This pandemic, though, is unprecedented in its scope and size, and there's so much more to learn about this virus. Moving on to the next slide, I wanted to remind everybody of what we're trying to do through all the methods that we're putting out there to flatten this pandemic curve, to prevent cases, to prevent the potential fatalities occurring. So our work in social distancing, of course, hand washing, and all the other efforts being put forth are so important to save lives. The next slide, I wanted to mention some of the fundamental public health interventions that are occurring. And that, of course, is testing, isolating infected individuals, tracing contacts and place individuals at risk in quarantine. And then when clusters of cases emerge, prohibit mass gatherings from occurring, which we are doing. Today, I just got this at noon today, so I wasn't able to include it in my slide, but the CDC in their Morbidity and Mortality Weekly Report put out a very important article today. And it's titled Pre-Symptomatic Transmission of SARS-CoV-2 in Singapore from January 23rd to March 16th. I highly encourage you to read this April 1st article so that you'll be more familiar with what's coming out from Singapore about the ability to transmit the virus before any signs and symptoms occur. So in other words, not an individual has fever or cough or any of the other signs and symptoms of influenza-like illness could still be transmitting the organisms to others. And they describe in this article transmission that potentially occurred under those circumstances. That's so important and impacts how we can control this. But it emphasizes greatly the importance of social distancing, avoiding congregate settings. And I'm so glad we're doing this by Zoom today. And we need to reduce the spread of COVID-19. So going on to the next slide, this reviews what CDC recommends: washing your hands often, avoid close contact with people who are sick, stay at home if you're sick, all these things that you're familiar with, cleaning, disinfecting our environments. I'm here in the laboratory today because we're considered essential services. My role here is essential to the lab, so consequently I have to work, but I need to be washing my hands, keeping my distance from everyone I come in contact with, and cleaning my environment regularly at the end of the day. So one of the things I wanted to comment before moving on to the next slide is there's a lot of things in the news and the media. One of them, someone talks about the risk from your groceries and other items. You know, when you come home, you put away your groceries, could any of that be contaminated? Could the bags be contaminated? Really questioning all that potential. And it's great to question those things, but it's probably getting too deep into it. We can't limit so much of our activities, but we should be washing our hands often. So like the first thing you come home from the store, the grocery store, where you've gone out to pick up your groceries, and you're bringing them into the house, before you handle anything else, wash your hands. Put them away and wash your hands again. So regular hand washing through the day and increased frequency than you have in the past is so important. Going on to the next slide, just want to review a little bit about what's happening in Iowa. This was from March 28th, so we had 64 test positives. That continues to grow. And then if you go on to the next slide, you see how the case count is spread through different counties in Iowa, and that continues to rise as well. And you can see that in the news. And the next slide gives you a county by county view. And if you're interested in this, you can find all this at the Iowa Department of Public Health webpage. As Bonnie said, it's an excellent resource to find out what's happening. This slide too, breaking it down by cases by age and gender, is extremely helpful. And as you can see, the middle age group at this time has more cases than the older adults or the younger adults, and more in women than in men. That could change as time goes on. So if you look at the cases by hospitalization data on this slide, most people are not going to be hospitalized. Most people will be discharged and recover, and only a few mortalities have occurred. The next slide is something that I try to do because I'm monitoring testing, because I want to make sure that we have the capacity to test what we need to test. So I was doing this on Sunday the 28th, and as you can see in the orange lines on the right, those are the projections with the confidence intervals for the upper and lower confidence bounds. So as you can see, we are on a trajectory to increase testing, and we are planning and ready to do so. The same thing for positivity. We see that increasing as we go forward as well. But much of what we're monitoring, as far as positivity and stuff, can be influenced by your work to maintain social distancing, to avoid crowds, to wash your hands regularly is so important in this. So, in encouraging your friends and neighbors to do the same. This is just about the tests that we're doing in the laboratory. We went live on February 27th. That was the earliest we got permission to do so from CDC. So that was right, they offered that throughout the country on that date. I wanted to show you this slide, this next slide. This shows you all the different companies that are making products that have FDA EUA approval. That's emergency use authorization. So as you can see, it's a long list of companies on this list, and some excellent products. And we're using the one that's listed last, the Centers for Disease Control and Prevention product, but other laboratories are trying other products. One of the problems everyone throughout the country is facing are supply chain issues. You've heard this on the news. Iowa is no different. And a lot of times, supplies are going to areas that are being prioritized because they are considered hot zones of infection. So consequently, they have a higher access to supplies than other parts of the country. Some commercial labs are on this list as well. Quest and Laboratory Corporation of America, LabCorp. So it's important to recognize when you send a specimen, if you're sending it to a hospital lab, they may do it in-house. A few of them are able to do so in Iowa at this time, and we really appreciate their support. They may forward it on to us, especially if the patient is hospitalized and meets that criteria that the Iowa Department of Public Health has put forth, or that may go to a commercial laboratory. Right now in Iowa, from the time of collection to the time of result availability, if it's sent to the state hygienic laboratory, our turnaround time is 41 hours. We try to test and have been successful at testing every specimen we receive each day. Now, in the commercial lab, if it goes to a commercial laboratory like Quest or LabCorp, it may take as long as 7 days or even as high as 10 days, depending on how busy they are and where they're receiving from. One of the other questions on the next slide is being addressed, and that's, would serologic tests be useful? Well, we talked about the use in that one question about the use of antibodies as a treatment. Well, we produce antibodies, and this slide gets to that. During the asymptomatic phase and then that window period, we first determine that IgM becomes detectable, and then IgG production occurs. So that's about 7 to 10 days where you'll see IgM production be detectable, and then about IgG about 14 days and longer. So there are tests available. They do not have emergency use authorization from FDA yet, but they're working on getting that. And I think this will be a very useful tool for epidemiologists for surveillance purposes and possibly for people returning to the workplace. And also, if they want to detect and use antibody for therapy, you need to know what titer that will be. So serological tests will be useful. My final slide is just a list of important websites. Give you the links for them where you can get really good information. So I encourage you to look for good sources of information. I am always amazed at some of the misinformation that is out there, particularly about this virus. So I suggest you try to help your friends and family get good information and reliable information. So I've gone really fast. If anyone has a question, we can take some questions now, Jackie.
Thank you so much to all of our panelists, and I know that that was a lot of information. So just to let the audience know, we're recording this and we will put it up on probably the College of Public Health website or something like that, so that you, and maybe it'll be in the same event page, so you can watch it again if you need to. So one question, well, a couple questions I have for the panelists. I think this will either be for Mike or Christine. Will a vaccine actually take a full year to develop, or is that just a conservative or worst case scenario perspective? And is it even possible to definitely have a vaccine?
Christine?
So I'll take a first shot at this and I'll let Mike chime in. So in order for a vaccine to reach use, normally it takes about 2 years from getting that DNA sequenced through the preliminary research, animal studies, then the phase 2, 3, and 4 trials in order to have a vaccine in use. So the year goal is incredibly ambitious. It's not a worst case scenario sort of goal. But the good news is, because we have had other similar viruses that have circulated but then gone away, that means that we have a trove of scientists who did some really great science and then were frustrated because they didn't get to, actually reach a vaccine. So that has allowed different groups around the world to be able to launch these programs much more quickly than we would have otherwise if it was a completely new virus family. But I do think, a year is going to be very ambitious. We're already in trials, but we're in the safety version of the trials, which is phase 2. We're going to look at that data and then go to phase 3, which allows us to actually start. And then we will lastly use it in the field, which is phase 4. And I do think a year, although very ambitious, is potentially possible.
Great,
thank you. Do you have anything to add, Mike?
I would say I agree with Chrissy's comments. I'm really hopeful, but the optimist in me wants to be hopeful, but the pessimist in me will say, well, they've been trying to make an HIV vaccine for over 25 years, maybe over 35 years now, and they haven't been successful. So let's hope, but we can't put all of our hope in that one product becoming available. We have to practice the social distancing and other recommendations now.
Okay, thank you. So another question is there any way of estimating the true number of cases in the United States, given that we are so behind on testing?
I'll take that one. I think that it would be very difficult to measure the true estimate in a disease where so many individuals have may not show any signs of symptoms ever, and may still transmit the virus to other individuals. So I think it's not only a testing problem, it's the way the coronavirus acts as a stealth virus that makes it very difficult to determine true estimate.
And Mike and Christine, this is Bonnie. Could you maybe talk to the fact too that do we really know when this virus came to the United States?
Well, I would say that it would be very difficult for us to know when it truly came, where the first case came from. I'm sure that in Wuhan, China, they are also not able to point to truly the first case of the disease, because a disease like this that doesn't always cause serious illness can go under the radar for quite a long time before it's detectable. Christy, is that your thought as well?
Yeah, I would certainly agree. The way this was approached originally was that China was the only place that it could come from. We banned travel from China to the US. Anybody coming back to the US from China, they were testing at, I think, 5 or 6 airports. Mike, you can correct me on what it was exactly. And then Washington happened, and we found cases that were happening outside of those hubs. Since then, we've basically figured out that this is spreading much faster than we thought, and we are behind on testing.
And remember, it was spreading at the same time as a number of respiratory viruses like influenza virus, adenovirus, parainfluenza virus, human metapneumovirus, the list goes on. And a physician diagnosing a case could think, well, this is just one of those other viruses, and the person will recover. So until we do serologic prevalence tests, we won't know.
Okay, thank you. For our last question, Mike, you touched on it a little bit, but what are some strategies for safely bringing mail, takeout, and groceries into our home? I'm specifically wondering about takeout, in which you might have to contact, another person or something like that.
Mm-hmm. Yes. I think that washing your hands is extremely important. So when handling containers and et cetera that you bring into your home from the outside, before you eat, wash your hands. Wash your hands after touching the containers. Wash your hands after disposing all of your trash. Important is hand washing. We don't know what the survivability on all the different surfaces is at this time. There's so much more to learn about this virus. But I think the reasonable approach to take is to practice good hand hygiene at all times.
Great. Well, thank you so much to our panelists. We had Christine, Bonnie, and Mike. I really appreciate you guys, and I appreciate all the participants for logging on. We will post this on the College of Public Health website, and be sure to stay tuned for more spotlights. Thank you.
Thank you.
Bye, everyone.
Thank you. It was a pleasure.